Hello, everyone. Thanks for joining us for the Clinical Case Review live stream event today. The Clinical Case Review is a monthly live stream program that takes place on the second Wednesday of the month at noon. This series provides a clinical case review followed by a discussion. If you wish to ask a question, please enter it in the Q&A box at the bottom of your screen. We'll discuss questions at the conclusion of the presentation. So to introduce our speaker today, Dr. Douglas Nelson. Dr. Nelson spent the early part of his medical career in the military service, leaving the United States Air Force as a lieutenant colonel in 2009. While in the Air Force, he served as the local principal investigator for a number of national oncology clinical trials. Dr. Nelson is board certified in hematology and oncology. He received his medical degree from the Uniformed Services University of the Health Sciences in Bethesda, Maryland, and completed residency in internal medicine and fellowship in hematology oncology at Wilford Hall Medical Center at Lackland Air Force Base in Texas. Before joining the Norton Cancer Institute, Dr. Nelson was an associate professor in the Department of Gastrointestinal Medical Oncology and Department of General Oncology at the University of Texas MD Anderson Cancer Center, The Woodlands in Conroe. Dr. Nelson served as medical director of MD Anderson, The Woodlands from 2014 to 2016. And with that, I'll turn the program over to him. And thanks for joining us today, Dr. Nelson.
Well, thanks. It's my pleasure. Happy to join you today and talk about colon cancer, certainly a common problem that everyone practicing medicine is going to see in some form or another. And so I'm going to try and share my screen here. Looks like it's up. So we'll get started today, and just make sure. Here we go. Click disclosure slide, and so we'll get started today with a case that I think will point out a couple of important issues. And so the case is a 45-year-old woman who is seen for her annual physical. She's been in otherwise good health, and she comes in really just for a routine exam without actual complaints. She does note heavy periods for many years, which haven't changed, and also says that she's had hemorrhoids and has occasional blood in her stool. She's up to date on her mammogram and her GYN evaluations, but she's never had any colorectal cancer screening. She doesn't have any family history of cancer. And so on routine lab studies, she has normal kidney function, normal liver function, and her CBC, she is noted to have a slightly reduced hemoglobin and hematocrit, hemoglobin of 10.2, hematocrit of 30.3, platelet count of 450. Her white blood count is normal, and her MCV is 78. So with that in mind, what would be an appropriate strategy for further evaluation of this patient? And here are your choices. Choice one, an oral iron supplement, and more than one of these could potentially be correct. So it's not just one answer. An oral iron supplement, management of her menorrhagia, stool samples to be submitted for either fecal immunochemical testing or fecal occult blood testing, Cologuard, or a colonoscopy. Okay, we've got a little bit of everything. Lots of popular answers there. So that's great because it gives lots of room for discussion. So we can close that. And just a few words, that's just the same choices. And then a few words about colorectal cancer. So colorectal cancer is the #3 cause of cancer in both men and in women. And so then together, it's the #2 cancer in the United States. And actually, I take it back. It's the #3 cancer, but it's the #2 cause of death. Because it's a common cause and also a common cause of death, it actually ends up being the #2 cause of death in the United States, a little over 50,000 deaths per year in the US. And if you look at this slide over time, you can see that the incidence of colorectal cancer has been declining. If you go back, to the middle of last century, there's been a clear decline. And a lot of that is probably related to screening and effective screening. But one problem that we have seen recently is that while there has been a significant decline in older ages, meaning over age 50 for both men and women, we're actually seeing a quite significant increase in the diagnosis of colorectal cancer in men and women under the age of 50. So a fairly significant increase, and something that we are clearly seeing in the clinic. These particular graphs are from Canada, but the exact same trends are seen not only in the United States, but also worldwide in developed countries. Another way of looking at that same issue is statistics like the following: that for folks born in 1990 compared to folks born in 1950, they have a 2 times higher risk of colon cancer and a 4 times higher risk of rectal cancer. Between 1991 and 2014, the risk of rectal cancer in patients under the age of 50 has doubled. And because of that increase in diagnosis at a younger age, that has actually brought down the entire median age at diagnosis. At one time, that was a median age of 72, and that median has dropped to 66. And so we really are seeing quite a problem with an increase in diagnosis in the younger age group. Because of that, that has started to impact recommendations about screening. But before we talk about the actual recommendations that are out there, it is important to review what do we mean when we talk about screening. So the first important point is that screening applies to patients who are considered to be at average risk. So it doesn't necessarily apply to everyone. So average risk meaning that they do not have a history of adenomatous polyps or a colon cancer history. They don't have any first-degree relatives with advanced polyps or colorectal cancer. They don't have a history of any kind of a genetic syndrome in themselves or their family that might increase the risk of colorectal cancer. They don't have a history of inflammatory bowel disease. We know that ulcerative colitis and Crohn's are 2 conditions that significantly increase the risk of colon cancer. So those patients are certainly not at average risk. And this is a less common issue now than it used to be, but patients have no personal history of abdominal radiation for childhood cancer. Back when radiation was more commonly used for lymphomas, especially Hodgkin's disease, there was a larger number of folks that had received radiation as a child or as a teenager for cancer. And then later on, they had an increased risk of secondary malignancies, including colon cancer. The other important point about screening is that not only does it apply to patients that are at average risk, but the word screening really implies that a patient is asymptomatic. And so that certainly has implications related to the case I presented. So somebody who complains of blood in their stools is not asymptomatic. And somebody who has iron deficiency anemia is also not asymptomatic. I mean, technically that's a lab finding, not a symptom, but the point being that screening applies to folks where you don't have any clinical concern that there might be something going on. So when we talk about the methods of screening, there's basically two broad categories. One of those is stool-based, and then there's structural-based screening. So the stool-based screening, there's the classic fecal occult blood testing. Then the more kind of modern adaptation of that, I think, is the fecal immunochemical testing. And then there's the stool DNA test. Currently, there's only one of those that's used and approved, which is the Cologuard. And I think most folks in the primary care community are becoming more and more aware of this as an option. It's something that, at least in the Norton system, you can actually type in Cologuard as an EPIC order, and it comes up. And then there's structural-based screening methods. That includes colonoscopy, flexible sigmoidoscopy, and CT colonography, although that is not used very often. Fecal occult blood testing has been around for a very long time. This is guaiac-based, and so it is based on a peroxidase reaction with hemoglobin that turns the paper blue. From a screening standpoint, when this is used for screening, while this is a method that is certainly validated because it's been tested in large trials, it is somewhat cumbersome because it requires dietary restrictions, and the way it has been done in tests and the formal way it is recommended is that 3 samples be submitted. The more modification of that I think is used more accurately is the fecal immunochemical testing. These are antibodies that directly react to human hemoglobin, which means they are not as affected by diet and medications like the guaiac testing can be. And it only requires 1 sample as opposed to 3 samples with the fecal occult blood testing. Testing for this is annual. The fecal DNA testing, or Cologuard, that is actually a combination of a fecal immunochemical test and an assay for DNA methylation markers that are associated with colorectal neoplasia and mutations associated with colon cancer. This also requires only 1 sample. It is not affected by diet or medications, and testing is generally going to be every 3 years. The advantages of stool-based tests are that they are convenient, they can be done at home, you do not have to do a prep, and you don't have to have a driver, which is sometimes an issue for folks that live alone or don't have family members or friends that are easily available to drive them. These tests are, especially the fecal occult blood testing and the immunochemical testing, are generally less expensive than structural-based tests, although Cologuard is certainly not inexpensive. And these tests can be done even in folks that have a lot of other medical conditions and comorbidities, where they might not be as good a candidate for sedation or for a procedure like a colonoscopy. On the negative side, these tests are not very good, certainly not as good at detecting adenomas as opposed to cancer. So they're better at detecting cancer, but of course, ideally, we'd like to detect adenomas and remove them before they ever have a chance to become cancer. And if you get a positive test with one of these stool-based testing, then all it means is you would then have to do another test, which is a colonoscopy. The structural-based testing, we're basically talking about either colonoscopy or flexible sigmoidoscopy. The advantage here is that they offer the option of prevention. Again, if you remove polyps before they ever have a chance to become cancer, then you are preventing cancer. So they offer the option of prevention in addition to screening. They don't need to be done as often, only every 5 to 10 years, as opposed to annually or every 3 years for a Cologuard. On the negative side, they require a prep, and at least for colonoscopy, patients have to undergo sedation, and they do have a small risk of serious complications. So what are the actual recommendations? And these have changed in the last few years in recognition of that significant increase that we are seeing in the under 50 population with colorectal cancer. And so for a long time, for many years, the age at which screening was recommended was 50. But beginning in 2018, the American Cancer Society dropped that screening age recommendation from 50 down to 45. And they recommend continuing to screen through age 75 and up to 85 on a case-by-case basis, depending on the health of the patient. They recommend either stool-based tests or structural exams. These have all been demonstrated to be effective in large screening trials, and so they're all included as recommendations. It took a couple of years for some of the other organizations that issue recommendations and guidelines to catch up to the American Cancer Society. But most recently, the U.S. Preventive Services Task Force in 2021 also dropped their age for screening recommendation from 50 down to 45. And again, including both options for stool-based testing or structural-based tests and direct visualization of the colon. So if we go and return to our case for a second and we talk about this patient. So I think the important points to highlight in the case presentation is that this is a patient who does complain of blood in their stools. Many patients often attribute that to hemorrhoids. And I always tell them you can blame it on hemorrhoids after you have had a colonoscopy. The other thing that is important in this patient's history is that she has a microcytic anemia, and that is at least suggestive of iron deficiency. Certainly that's not the only thing that can cause an iron deficiency, a microcytic anemia, but iron deficiency is certainly the most common reason for folks to have a microcytic anemia. And for folks that are really sharp, they'll have noticed that this patient does have a slight thrombocytosis, and a reactive thrombocytosis is often seen with iron deficiency anemia as well. So, for this patient, in terms of appropriate strategies, it is certainly appropriate to manage their menorrhagia. That is often a contributing or the cause of iron deficiency anemia in women. And so that's always appropriate. And sometimes they will be put on some type of oral contraceptive or other hormonal manipulation to try and improve menorrhagia. And then a colonoscopy is really appropriate. So I don't think that in this patient that the word screening would really apply. This is a patient who has had blood in their stools and has iron deficiency anemia. And so sending stool samples for testing for occult blood and sending a Cologuard, those are simply not appropriate. If they come back negative, this patient still needs a colonoscopy. And as far as an oral iron supplement, that might certainly be appropriate, but I don't think you would want to go too far down that path with a medication that might turn their stools black and further, confuse the picture until you've evaluated more fully what the cause is with a colonoscopy. So let's continue on with the case. So now this same patient is sent for a colonoscopy, and they are found to have a mass in their sigmoid colon. A biopsy confirms an invasive, moderately differentiated adenocarcinoma, and a CT scan has no evidence of metastatic disease. And so I think we have our second poll question of what would be appropriate management at this time. Your choices are PET scan, neoadjuvant chemotherapy prior to surgery, resection, or a genetics evaluation for germline testing. Okay, and we've got a good mix again. So let's talk about it. Okay, really, I would say at this point, PET scan is rarely needed prior to definitive management of a colon cancer if a CT scan is negative. The main role of a PET scan would be, I can think of two circumstances where a PET scan would be appropriate. One is if there are confusing or uncertain findings on a CT and you feel like you need to characterize those findings further. The other indication for a PET scan would be if there was a patient who, for one reason or another, could not get IV contrast. Certainly the standard for a CT scan in this situation would be a contrast CT scan. And so if a patient, say they had significant renal dysfunction and they could not receive IV contrast, that would be a reason to consider a PET scan. But the majority of patients do not require a PET scan. A CT, if it shows no evidence of metastatic disease, is appropriate. And as far as chemotherapy, generally for colon cancer, which this patient had, we very rarely give chemotherapy before surgery. The usual first thing that is done to actually treat colon cancer is to remove it. And then we make decisions about chemotherapy based on the pathology. Rectal cancer, we'll talk about in a little bit, but the situation is a little bit different with rectal cancer. So certainly resection would probably be appropriate at this time. And this patient should have a genetics evaluation for germline testing. And we'll talk a little bit more about genetics in a future slide. So as far as the treatment of early stage colon cancer, as I was just mentioning, most patients, the initial treatment is surgery. And then based on the stage, we decide whether there is a high enough risk to justify giving chemotherapy in the adjuvant setting to reduce the risk of recurrence. Stage 1 cancers, where there is invasion only into the submucosa or the muscularis of the colon, we never give adjuvant chemotherapy. On the other hand, stage 3 patients who, by definition, the definition of stage 3 is node positive. So stage 3 patients, we will almost always recommend chemotherapy, assuming a patient is otherwise in good enough health to receive chemotherapy. And then for stage 2 patients, that is somewhat controversial because the amount of benefit is going to be lower, but that is on a case-by-case basis. Sometimes we will recommend chemotherapy and sometimes not. I'm not going to talk too much about chemo itself, but 5-FU and the oral form of that called capecitabine or Xeloda, that's been the the backbone of chemotherapy for colorectal cancer for many years. And then we often add a drug called oxaliplatin, which gives us FOLFOX or CAPOX as a regimen, and that's given anywhere from 3 to 6 months. Rectal cancer, as I mentioned, is a little bit different. The main issue is that historically, when we look at the incidence of local recurrence of cancer in the area where the cancer was to start with, the incidence of a local recurrence has been much higher in rectal cancer compared to colon cancer. And a lot of that has to do with the small confined space of the pelvis that a surgeon is working in. And so that has been a real problem. And of course, local recurrence in the pelvis of a rectal cancer is a major clinical problem and a source of a lot of morbidity for patients. That has improved with better surgical techniques, such as a total mesorectal excision. And this is really kind of a specialized surgery, such that I would probably argue that in most cases, rectal cancer surgery should be done by a colorectal surgeon or a surgical oncologist, and generally not by a general surgeon. As far as colon cancer surgery, certainly that can be done well by a variety of surgeons, including good general surgeons. But rectal cancer surgery is a little bit of a different animal. And also because of this history of high incidence of local recurrence, chemotherapy and radiation are often given prior to surgery in the cases of rectal cancer. The one other thing that I'll mention that is becoming more and more clinically relevant for rectal cancer is that we are discovering that with the combination of both chemotherapy and chemoradiation prior to surgery, that in fact, we are seeing a higher percentage of patients where they receive chemotherapy and chemoradiation and the tumor actually disappears. And some of those patients are then eligible for what we call non-operative management, where they can be watched closely with serial imaging and serial scope rather than undergo surgery. And so they may be able to avoid surgery, which is especially important for low-lying rectal cancers, where surgery for a tumor that is near the distal rectum, near the anal verge, surgery in that case means a permanent colostomy. And so the ability to be cured of cancer, and in some cases without having to undergo surgery, they're not just avoiding surgery, but they're avoiding colostomy for the rest of their life as well. So that is certainly being done more frequently now than it has been in the past. One slide about genetics. I think most folks have heard of Lynch syndrome, and we test every colorectal cancer for evidence of Lynch syndrome. It's the most common cause of a hereditary predisposition to colon cancer, and it's about 3% of patients, although if you look at the under 50 crowd, that number is higher. Although I will point out that still the vast majority of patients under the age of 50 don't have some type of hereditary predisposition that we can identify. Sometimes folks think that they're under the age of 50, that folks are too young to get this type of cancer unless they have some kind of mutation, and that is really not true at all. If you think about 150,000 cases of colorectal cancer a year, and 3% of those have Lynch syndrome, that's almost 5,000 patients a year with Lynch syndrome. So not a small number. We assess for the suspicion of underlying Lynch syndrome with either immunohistochemistry, looking for the so-called mismatch repair or MMR proteins, or we can do PCR testing for microsatellite instability. In the case of a patient under the age of 50, we will usually refer them for germline genetic testing, even if the MMR testing or the MSI testing is not suggestive of Lynch, because there are certainly other syndromes that can predispose to colorectal cancer, and the incidence of those goes up significantly when you look at patients developing colon cancer at a younger age. And then the last thing to say about the importance of doing this testing is that when we test for microsatellite instability or for MMR deficiency, it's not only that we're looking for Lynch syndrome, but that the results of that testing also has both prognostic and predictive implications. It implies a better prognosis for early stage cancer, and in advanced cancer, it implies sensitivity to immunotherapy. And so it allows us to potentially offer other options for treatment if we find it. So it has implications both for how we manage patients, and then of course also in terms of their family history and family testing. So to continue on with our case, if we say that this patient, was treated for her colon cancer, and 2 years later, unfortunately, is found to have a recurrence with 2 liver metastases, what would be appropriate management? And so I think, do we have one more poll? No, we don't. This is just a segue to talk about the treatment of advanced disease. And again, I'm going to very much gloss over this, but a couple of points to make. Number one is that this is often treated with a combination of chemotherapy, targeted agents, and also sometimes local therapy. There are patients with metastatic disease that can still be cured with a combination of drug therapy and some type of local therapy, such as resection. Molecular profiling is very important. And I briefly mentioned just a minute ago that immunotherapy sometimes has a role. We used to approach these cancers all the same, but now we know that you really have to think about the molecular findings that you see in a tumor, and it's really more like a pie, and a whole bunch of small little slices of the pie, where even though those percentages in many cases are not a large number of patients, the treatments that we offer can be quite a bit different if they fit into one of those small little slices. And so without going into them in much detail, the main point being that if you don't look, then you won't find. And we need to look. And so we do routinely do molecular profiling on patients with advanced disease so that we know that we're offering them all the potential options that they're eligible for. Last topic that I'll mention, and I think this is something that you're going to hear more and more about and need to be aware of, and that's circulating tumor DNA. The main point here is that if there are tumor cells somewhere in the body, those tumor cells, there's a certain number of tumor cells that are new at any given time, that as cells divide and grow, and then there's also natural apoptosis of some of those cells. And when some of those cells undergo apoptosis, they release their DNA into the bloodstream, and it's chewed up, but for at least a period of time, it can be detected, that cell-free DNA can be detected in the bloodstream. If you've heard the phrase liquid biopsy, this is what we're talking about. This is also referred to as MRD, or minimal residual disease detection. It's the ability to detect these fragments of tumor DNA that are circulating in the blood. And so what we're finding is, if you look at stage 2 colon cancer, so somebody who has undergone resection, stage 2 disease, pretty good prognosis, and you say, okay, well, that's on average, they have a pretty good prognosis. Well, if you do a ctDNA test, a circulating tumor DNA test, if that test is positive, then their good prognosis is actually really bad. Their prognosis actually is that they are very likely, almost 100% likely, to have a recurrence of disease. That might not be evident for many months on imaging, but if their ctDNA is positive, they are probably going to recur. And likewise, if their ctDNA is negative, then it gives you even more assurance that they won't recur, and that they do in fact have an excellent prognosis. We're seeing this in stage 2 patients, stage 3 patients, and we're starting to use these tests on a more routine basis to help us make decisions about treatment. This is a trial that we're opening, just have opened here at Norton, and it uses this test, the circulating tumor DNA test, to help make management decisions. And so now we're taking stage 3 colon cancer patients. Standard treatment is chemo. So after surgery, these patients usually get chemotherapy. But if they have negative testing of circulating tumor DNA, then they are randomized where they could receive surveillance, which we wouldn't generally do. But we think that the ctDNA test may be so good that it may select out patients where they don't need chemo. On the other hand, if the ctDNA is positive, then their risk of recurrence is so high that we actually are randomizing those patients to an escalated regimen where they get more intensive chemotherapy because we feel that their chance of recurrence is so high. And then last thing to mention is that this same technology, looking for these small fragments of circulating tumor DNA, this is now being incorporated into screening so that patients are able to just submit a blood test that can look for little fragments of tumor DNA, and that can be a way of trying to screen them for cancer when they have never received a diagnosis of cancer at all. And you've probably heard or maybe have seen occasional stories about these tests where, one sample of blood and they can be screened for multiple different cancers all in one. And these tests are actually available. They're not standard, they're not recommended, they're not paid for by most insurances, but they are available even now. And they're being looked at in clinical trials, and they're not bad. So if you look here, the ability to detect stage 2 or stage 3 cancers in colon cancer, esophageal cancer, gastric, pancreatic, biliary tract cancers, this is just the GI cancers. These tests are pretty good at detecting cancers at a stage where they may still be potentially curable. And so there are large studies undergoing that are going on now to really test this strategy. And so in the next 5 or 10 years, instead of a colonoscopy, you may just submit a blood sample as part of screening for colorectal cancer. That's all I have, and I'm certainly happy to answer any questions.
Thank you so much. I think all of us got quite a bit out of that. I currently don't see any audience questions, but I did write down quite a few, so have no fear. You're not off the hook quite yet. So are there theories behind the increased incidence in the younger population?
Yeah, there's a few theories, and I don't know that there's any definitive answers. Two theories that I've heard is one, that it just may be related to changes in our diet over time, more processed food, more chemicals in food, or toxins, used in crops and such. That's one theory. And then the other theory that I've heard is that perhaps it is related to changes in the gut bacteria that occur with the frequent use of antibiotics. And so those are two theories that I've heard to explain why we may be seeing a much higher incidence in the younger population, but I don't think anybody knows for sure.
Okay. And then with that, keeping that in our thought process, so what should the primary care audience that we're speaking to today, what should they look for, be on the alert for due to the increased risk of rectal cancer in younger people?
Well, so as you say, rectal cancer, these are more commonly left-sided tumors, but you can see, anywhere. I think the main take-home point is that just because someone's in their 30s or 40s, they can still get colorectal cancer. And so, as I say, I tell people you can blame it on hemorrhoids. You can blame that blood in your stool on hemorrhoids after you get a colonoscopy. And so, that's something that's going to be important to proceed with testing, and not just blow it off or attribute it to other causes, even when folks complain of heavy periods or obvious hemorrhoids.
So did I recall the slide correctly when you were talking about the population that was 1990-ish, that the incidence of rectal cancer, so colon cancer was like twice as likely in that age group as it had been, and then it was like 4 times as likely for rectal cancer. Do I remember that correctly?
Yes, that's exactly correct. And so, there's been this increased risk overall, but especially in the left side of the colon. And I don't know that anybody knows the exact reason why left-sided tumors have increased more than right-sided tumors, although everything has increased.
So a question actually I had written down that one of our primary care providers posted was, is there a correlation between the increased incidence of HPV and the rectal cancers in particular?
No, I wouldn't say that. We don't know of a relationship between colorectal adenocarcinoma and HPV. HPV is really linked to anal cancer, which is a squamous cell cancer,
Sure.
Not to adenocarcinoma.
So another question that has come in, at what frequency typically is the ctDNA drawn? 4 weeks, 12 weeks, 6 months, annually?
Yeah, good question, because we don't know the answer. We don't really know the answer to that question. When we are monitoring patients historically, we've used the CEA blood test, the carcinoembryonic antigen blood test, and we still do. It's not that we're not using that; we still do it, and we do that generally every 3 months for higher risk patients. So every 3 to 6 months, we get a CEA test, and so we've kind of extrapolated from that. And when we do follow ctDNA, that's what we're doing. But we don't really know that that is the appropriate interval. I mean, it may be that 1 or 2 tests might be enough, and maybe you don't need to keep getting it. That is one of the unknowns. There's a lot of unknowns, and that's one of them.
So another question is, in the graph that showed the percentages of men and women in their diagnoses, is that based upon US numbers or global? And do you know, is there a big difference between the United States and Europe?
I don't think there is much of a difference between United States and Europe. The numbers that I showed, the charts that I showed, those were US numbers. And those, actually anybody can download those. If you Google cancer facts and figures, the CDC puts out updated numbers every year. And so, or actually not the CDC, it's the American Cancer Society, I think. But they update those and make that data available every single year. And those numbers are US.
So what, in thinking about this as a totality, so the colon and rectal cancer, what are the main differences from a presentation standpoint? And then what we in the frontline primary care world should know and do any differently in considering one or the other?
Well, I think that the main difference is that folks that have a tumor in the left side of the colon, such as the rectum, they are more likely to present with hematochezia, and I think a little bit more likely to have symptoms like cramping or discomfort, and perhaps more likely to have change in bowel habits. for folks that have a very right-sided tumor, such as in the cecum or the ascending colon, those are often a little harder to detect. They're not as likely to result in visible blood in the stool. And until later in their course, they're less likely to produce symptoms because, again, on that side of the colon, the stool is still, very, liquidy. And so, they're less likely to be symptomatic related to the enlarging tumor that's in that colon. So it is harder, I think, as far as symptoms to detect somebody with a right-sided tumor as opposed to a left-sided tumor.
So I think the bulk of us are familiar with, as you mentioned, familiar with Lynch syndrome and the terminology. Remind us of the other cancers that are associated with Lynch syndrome.
Yeah, so Lynch syndrome, the two most common cancers associated with Lynch syndrome are colorectal cancer, and the risk of that does depend a little bit on which gene is mutated. So there's potentially 5 different genes that are mutated to result in that phenotype. But colorectal cancer is the most common, along with endometrial cancer. So endometrial cancer and colon cancer, but also can be involved in pancreatic cancer, ovarian cancer, cancers of the upper urothelial tract, like ureteral cancer, and sometimes an increased risk of upper GI cancers like small bowel adenocarcinoma or gastric cancer. So there are a variety of tumors that have an increased risk, but by far the two most common are colorectal and endometrial.
But if we have a patient that has any one of those, and whomever is treating that has not gotten the studies to look at genetically whether they might be a part of Lynch syndrome, that's something that we should consider sort of pushing for those patients, or
it's something that we should at least consider it. Yes, absolutely.
okay.
Absolutely.
So it appears, because I wasn't aware of all of the antibody type treatments that are available, et cetera. It appears that we're sort of flipping the script on colorectal cancer, much like we have with breast cancer, where when I was in training, if you had some of the genetic markers, it portended for a very bad outcome. Whereas now you actually want those because it gives us more certain treatment targets. So it appeared from what you were saying that is the case with colon cancer. We're getting closer to having those better targets and better treatments for those. Is that true, or did I take that wrong?
No, I'd say that that's true in general, and this is true for not just colorectal cancer, but most cancers, that when we find specific molecular targets for which we have treatments, that those treatments are more effective than, say, kind of the generic chemotherapy that we would use, for the larger group. So usually some form of targeted therapy has a higher chance of success compared to the same kind of average treatments that we would use for everyone else. In the case of colorectal cancer, when we find patients that have microsatellite instability, we know that they have a very good chance of responding well to immunotherapy. And there are even some patients that are potentially cured of advanced disease with immunotherapy. There was a publication in the New England Journal and a presentation at a major cancer meeting recently that made headlines, in which they gave immunotherapy before surgery to about 14 rectal cancer patients that had microsatellite instability. Some of them had Lynch, some of them had microsatellite instability for other reasons, but patients that had microsatellite instability got immunotherapy alone, and the tumors disappeared in every single patient. And those patients have not required any other treatment, no chemo, no surgery. We're not to the point of that being standard practice, but it certainly is proof of principle, and it obviously gets a lot of attention.
So this question comes with a caveat that I know that I'm asking for at least some measure of supposition. But do you believe that we will be moving towards, in the next 5 to 10 years, and you alluded to it in one of your last slides, where there will, for people who are at normal risk, colonoscopy is probably not going to be the initial test of choice for them. There will be some of the genetic components that are tested, et cetera, and doing more blood sample work rather than the actual visualization of the colon.
Yeah.
And we'll move more towards surveillance for colonoscopies for people who are at higher risk or have already had polyps, et cetera.
I think that that's true. I think, there's always going to be people that have blood in their stools or have some other symptom where, it is appropriate to actually look. But when
purely screening.
For purely screening, I certainly think that we're going to, I believe that, in X number of years, whether that's 5 years or 10 years or what have you, that, yeah, it's just going to be a blood test, I believe. And honestly, I think the, Cologuard is, all the things that people like about Cologuard, the fact that they don't have to do a prep, they don't have to give up a day of work to come for the test, et cetera, the cost, all the things that people like about Cologuard, they're going to like even more about just having a blood test. And so I think that especially tests like Cologuard, the days for Cologuard are limited, because if you can get the same information from a blood test, then why wouldn't you just do a blood test? And I think for average risk patients, screening, that we are going to get to a point where just doing a simple blood test is going to be one of the options that's available.
I don't see any further questions. I really appreciate your presentation today and the response to all the questions. I know I sort of went in depth with some of them and put you on the spot, but I appreciate it.